Hello, everyone. My name is Deanna Fenton, Program Manager here at the Alliance, and I'd like to thank you for joining us for today's webinar, Protect the Skin You're In, Early Detection and Prevention of Skin Cancer. Before we begin today's presentation, there are a few housekeeping items that we'd like to review. For optimal visual and audio experience, we do recommend accessing these webinars in the Chrome browser. If at any point you encounter any issues, please log back in using Chrome. If you're already using Chrome or continue to experience audio issues, please dial in using the phone number that was provided in your confirmation email. Now, to those of you who are joining us for the very first time, please take note of the chat feature that's located in the bottom left-hand corner of your screen. This chat should be used to pose your questions to our speaker. If you have any questions that come up during the webinar, please feel free to submit them at any time. Once the presentation concludes, we'll have some time for our presenter to address as many of your questions as time allows. Now, for those of you who may be interested in our upcoming webinars, please note registration is currently open for our next webinar, Referrals on the Rise, Strategies for Improving Timely Organ Referrals. That's coming your way on September 10th at 2 p.m. Eastern. Registration is also open for our upcoming innovation webinar entitled Innovative Donor Management in In-House Recovery Centers. Be sure to join us for that on September 19th at 2 p.m. Eastern. You can register for all these webinars and more on our website at organdonationalliance.org. Now, for anyone interested in obtaining continuing education credits, we are offering 1 SEPC credit and 1 nursing contact hour for this webinar. Please note we also offer a certificate of attendance. For anyone seeking CEs that are not available, we recommend submitting a certificate of attendance to your credentialing organization as proof of your participation in this educational offering. Everyone joining us today is entitled to claim either of these credits or certificates. Prior to receiving your certificate, you will be asked to complete a brief online evaluation that will allow you the opportunity to provide us with your valuable feedback. If you're listening in a group, please be sure to get the evaluation email from your group lead. As a reminder, for nursing, you'll have 14 days to complete your evaluation and claim your credit, and for SEPC, you'll have 30 calendar days. Now, at this point in time, I'd like to introduce our moderator, Rebecca Brown, Nurse Manager of Transplantation Services at UPMC Pinnacle. I'd also like to take this opportunity to introduce our presenter for today's webinar, Dr. Sarah Arron. Dr. Arron is a physician scientist with 10 years of experience in dermatology and translational research. She is passionate about bringing innovation and informatics to the field of dermatology. She runs a translational research laboratory focused on the genomics and metagenomics of cutaneous squamous cell carcinoma. She is an active consultant for startup companies in the dermatology specialty and serves as a subject matter expert for pharmaceutical companies in the area of skin cancer and trial design. Dr. Arron, we're so glad that you can join us today, and at this point, I'll turn it over to you. Thank you.
As you can see in the far right, solid organ transplant recipients have far and away the highest risk compared to the general population, and that's nearly matched by patients who are immunosuppressed due to hematologic malignancies or bone marrow transplant, as well as HIV. But it's that solid organ transplant group that I have become most passionate about, and that's what I'm going to discuss with you today. So some skin cancers are relatively easy to recognize and don't take a lot of complicated training to see that there's a problem. On the left, a classic basal cell carcinoma. In the middle, a very large cutaneous squamous cell carcinoma. And on the right, a concerning melanoma. But the truth is the vast majority of skin cancers that I see and diagnose are significantly smaller and less easy to recognize. And so again, here on the left, we have a very subtle indurated basal cell carcinoma. In the middle, an early squamous cell carcinoma, the red patch. And on the right, in a young patient, a very small mole that actually turned out to be a melanoma in situ. And so what I want to do starting off on this talk is just review the basic types of skin cancer to give you a framework to understand the data that I'm going to share with you for our transplant patients. Basal cell carcinoma is far and away the most common cancer in the United States and around the world. There are over 4 million of these cancers diagnosed every year, the vast majority on the head and neck and due to sun damage. And these are very locally invasive tumors. They have an incredibly low risk of metastasis, and it's very uncommon for them to cause any problem to the patient beyond the nuisance of having a lesion that has to be removed with surgery. And there are multiple types of basal cell carcinoma, some of them illustrated in these photographs. On the upper photograph, a nodular basal cell carcinoma, which has a classic pearly rolled border around an ulceration in the middle. On the lower left, superficial basal cell carcinomas, which appear as crusted patches. And then on the lower right, morphiiform basal cell carcinoma, and here in a background of multiple other skin lesions, morphiiform basal cell carcinoma can sometimes look like scar and be difficult to recognize. Now, squamous cell carcinoma is the second most common in the general population, but is the most frequent cancer in transplant recipients, and that's what I'll be talking about the most today. In the U.S., there are over 1 million squamous cell carcinomas per year, but neither basal nor squamous cell carcinoma are captured or counted by cancer registries, such as the SEER registry. And so it can be very, very difficult to have accurate population-based data around these two cancers. Like basal cell cancer, squamous cell carcinoma arises in sun-damaged skin on the head and neck or the backs of the hands, and they can begin as precancerous, scaly red patches that we call actinic keratosis or AKs, and our patients often can recognize them as the lesions that we freeze with liquid nitrogen spray. And squamous cell carcinoma is a significant problem for transplant recipients beginning at a much younger age. As you can see on the lower right, this is a woman in her 30s with a patch of invasive squamous cell carcinoma on the lower lip after lung transplantation. On the upper right, a photograph of what we call transplant hand, so weather-beaten, sun-damaged skin with multiple freckles, lentigines, and then these thin, scaly patches in which arise squamous cell carcinoma. Some of these patients get multiple primary tumors, even more than 10 per year, and these can result in a significant amount of morbidity as well as mortality to our patients. And then finally, the third most common type of skin cancer is the one often lay people think about the most, which is melanoma. And melanoma is not nearly as common. There are only about 100,000 per year in the U.S., but the mortality from these cancers is significantly higher. The incidence of melanoma is continuing to rise over this century, most likely due to increases in sun damage as well as our ability to detect these tumors. And we teach our patients to look for changing or new pigmented lesions. The prognosis of these lesions really depends on how thick they are and how early we catch them. And so frequently in dermatology, we teach our patients what we call the ABCDEs of melanoma, although I like to tell patients these are the ABCDEs of any lesion you find on your skin that should be reviewed by a physician. And those include A for asymmetry, B for an irregular border, one that's difficult to draw a clear delineation around. C is variations in color, so not just a single dark brown lesion, but one like the lesion on the upper right that includes both red, black, and then a bluish-gray veil. D is for diameter. I tell patients anything bigger than 6 millimeters or the size of a pencil eraser should be brought to our attention. And then E, which is a lesion that's evolving or changing, either in size or color, texture, or ulceration. And there are certainly benign skin lesions that meet all of these criteria, but it's a very sensitive way for having patients draw things to our attention for a closer look. So why do we care so much about these skin cancers in our transplant patients? Well, this is data just from my clinic here at UCSF. These are the first squamous cell carcinoma after the time of transplantation, and you can see in the blue kidney, liver, and pancreas or abdominal transplants, and in the red are heart-lung transplant recipients. And by 5 years post-transplant, the lung transplant patients, at least a quarter of them will develop a squamous cell carcinoma. By 10 years post-transplant, a quarter of our kidney, liver, and pancreas patients. And so as our patients are living longer with improved immunosuppression, we're starting to see more and more of these late post-transplant complications. And I have 4 of my own patients here just illustrated in the upper right. The 2 lesions on top are relatively small lesions on the lip. Both are straightforward, easy to remove surgically. The lesions down below are far more complex, have grown to a greater extent. The woman with the squamous cell carcinoma on her arm has already had multiple recurrences and metastasis. And identifying them this late in the game makes it very, very challenging to treat. So my primary interest is in identification and prevention of these these skin tumors. So I've been fortunate to be a member of multiple organizations focused on skin cancer after transplantation. And what I want to share with you today is research from what we call the Transplant Skin Cancer Network. And this is really a research collaborative network, which was initiated by the American Academy of Dermatology with the goal of focusing on multi-center studies of skin cancer and organ transplant recipients. And as I mentioned before, we don't have SEER data or other cancer registry data on squamous cell carcinoma, so our initial goal was really to identify what is the population-based incidence and the predictors of post-transplant skin cancer, including squamous cell carcinoma and melanoma in the United States. So this group performed a retrospective review of all the transplant recipients who received an organ at 26 centers in the United States, and we selected 2 years for study, 2003 and 2008. And we did that to allow us a 5- and 10-year follow-up, and we wanted to include changes, as I'm sure you are all well aware of, in transplant immunosuppression that occurred in the earlier part of the 2000s. So as part of this study, we reviewed records from 10,000 transplant recipients contributing 60,000 years of follow-up. And our goal was to get this data so that long-term we can target screening to the patients who are most likely to benefit. And this was published in JAMA Dermatology a few years ago. As you can see, there are at least 80 physicians on this paper, many supporters of this research, and these are the centers that participated. Participation was open to any center and still is. Primarily, we are looking for centers that have a dermatologist who is focused on transplant patients and a transplant team interested in skin cancer research. So I'm not going to go through this complicated figure in great detail except to show that our study cohort represented about 25% of the total transplant population in the years under study. But our cohort was slightly different in that our patients were older, they were more likely to be male, they were more likely to be white, and more likely to have a thoracic organ transplant than the general transplant population. And we believe that's because the majority of our centers were academic healthcare centers, many of them doing more heart and lung transplants than our community transplant centers. But nevertheless, we were able to collect data from detailed medical record review looking at the skin cancer incidence in this population. And so for the first time, we really had a scope of the problem. The incidence rate for squamous cell carcinoma in our post-transplant population was 1,355 per 100,000 person years. So that's nearly 10% of our patients developing a squamous cell carcinoma at some point after transplant. Melanoma incidence rate was 125, so tenfold less. And Merkel cell carcinoma, which is a very rare type of tumor, was indeed very rare in our population as well. There were only 2 in all of the patients that we studied, so we really can't report strong statistics around that except to say that it is a very rare cancer in this population as well. We also looked at the incidence rates broken down by some of the known risk factors for skin cancer, and we're not surprised to discover that men have a higher risk than women. White patients have a higher risk than non-white patients, but the incidence in non-white patients was not 0. These patients are at risk as well. Heart and lung transplant recipients had a much higher incidence than abdominal transplant recipients, which we believe is due to higher levels of immunosuppression as well as the immunogenicity of the lung as an organ. Patients who were transplanted over the age of 50 had a higher incidence, and interestingly, patients who were transplanted in the more recent era had a slightly higher incidence, and we don't really know if that's because these patients are otherwise better controlled and have a healthier cohort able to then have skin cancer surveillance, or if these patients have some medication or transplant-specific risk factor that we didn't study here in this cohort. So we're interested in learning more about that. When we put this incidence in context, we wanted to compare these rates to two populations that had been reported in the past. One comes from a study called the Transplant Cancer Match Study. So this was a study done at the National Cancer Institutes where they matched the National Cancer Registry from OPTN to the SEER Cancer Registry. Now again, because squamous cell carcinoma is not in the SEER registry, they had no data on this tumor, but they certainly had data on melanoma and other cancer sites. The second group we compared to is the U.S. population SEER data overall. And so what you can see is that looking at cancers of all sites in the U.S. population, the incidence rate is 442 per 100,000 persons. In the transplant cancer match study, it's significantly higher, not surprising because of immunosuppression. All sites together was 1,300 per 100,000 person years. When we look in our data at cutaneous squamous cell alone, you can see that our incidence matches virtually all other cancers combined out of SEER registry data. So this is a significant problem for our transplant recipients. Our melanoma rates, 125 per 100,000, were slightly higher than reported in the transplant cancer match study. We don't know if that's because we are biased towards centers with dermatologists and therefore greater surveillance, or because the data from 2003 and 2008 are not quite generalizable to the data from SEER in 2011, but it's on the same order and significantly higher than the U.S. population otherwise. And then I've included some other common cancers below just to put that into the context and give you a sense of how significant the problem is. But it's not enough to say that these patients get so many squamous cell carcinomas. For most lay people, a squamous cell carcinoma of the skin is treated surgically and doesn't go on to lead to any morbidity for the patient. But for our solid organ transplant recipients, even small benign-looking squamous cell carcinomas can lead to mortality very rapidly. So on the left, a patient of mine with a very small squamous cell carcinoma on his scalp, which led to both in-transit lymphatic metastases and lung metastases. On the right, another heart transplant patient of mine with a relatively small squamous cell carcinoma on the arm who developed lymph node and then dermal metastases as well. So these are the types of situations that we're really trying to avoid for our patients. And when we went to study mortality of skin cancer in our transplant recipients, again we found there was very little registry data to look at. So our group downloaded all of the cause of death data from the OPTN, the UNOS database, for the years of 1987 through 2013. We had nearly 500,000 transplant recipients in that population, and we very carefully did some natural language search processing to look for patients with squamous cell carcinoma listed as the cause of death. In this population, we found that the risks for mortality from squamous cell carcinoma and from melanoma were very similar to the risks for incident tumor. The patients who get more cancers are also more likely to die from these cancers. So older patients, white patients, male patients, and the heart or lung transplant recipients. And putting this data into context with the overall U.S. mortality, we find that, of course, overall mortality in transplant recipients is significantly higher, 5,000 per 100,000 person years. But when we look at OPTN data for death from melanoma, we find 11 per 100,000 person years. It's nearly 5 times higher than the U.S. mortality rate, which was estimated at nearly 3 per 100,000. We find death from Merkel cell carcinoma, which is not captured in U.S. registry, at nearly 5 per 100,000, and interestingly, squamous cell carcinoma as well, nearly 5 per 100,000. Now, we think of Merkel cell as an extraordinarily rare but lethal tumor. Squamous cell carcinoma is an extraordinarily common but less aggressive tumor, but in fact, the same number of patients are dying every year, and so they both deserve scrutiny. So what do we do? How do I approach skin cancer risk in our patients? I want to share with you some of my approach and also some tools that you can use in your practices as well. I'll talk about screening and early detection, what we call chemoprophylaxis and field therapy for prevention, ways that we can work together to optimize systemic medications, and then some tips for our patients on sun protection and sun avoidance. So obviously when we talk about cancer, we think about cancer screening, and we all know about guidelines for colonoscopy for colon cancer screening or mammography for breast cancer screening. We don't have formal guidelines for skin cancer screening, and certainly none for skin cancer screening after transplantation. In 2004, the ITSE, International Transplant Skin Cancer Collaborative, and the European Partner Scope, or Skin Cancer and Organ Transplant Patients, put together an expert opinion where they basically as a group said, well, we should see every patient every year. And if they have a history of sun damage or skin cancer, we should see them more. This opinion, which was casually tossed off in a paper that a group of my colleagues wrote, was then picked up and spread as gospel. So for many, many years, we've been saying we should screen every transplant recipient every year. But the truth is that comes from dermatologists, and if you look at practice patterns, most transplant providers don't refer every patient to be screened every year. And even in the field of dermatology, we know that not every patient truly needs to be screened every year. We don't have data to show that it reduces mortality. And the U.S. Preventive Task Force really only recommends cancer screening in cases where it can reduce mortality. There was a study in Germany in 2008 looking at screening and reduction of melanoma mortality, and originally their preliminary data showed that it was effective, but then when they expanded the study to a broader population, they found that the results didn't hold. And so right now, Preventive Services calls skin cancer screening by dermatologic examination insufficient, or category I, to balance the benefits and harms. And they do make the caveat that perhaps high-risk patients, such as transplant recipients, will benefit from screening, but we really don't know. And when we talk about whether we should screen patients, well, yes, there are potential benefits, but there are also potential harms, and I think it's important to go over these together. Referring a patient seems like a no-brainer. You send them to dermatology. It's not even an invasive test. We just look at their skin. So we have the potential to reduce skin cancer morbidity and mortality by identifying tumors early. We certainly have the opportunity to educate patients about their sun exposure and modifiable risks. We have the opportunity to intervene if they're on medications that are associated with increased skin cancer risk, and then potentially to see patients for other transplant-associated conditions like skin infections or warts. But the truth is screening is not the same as dermatology referral. When we talk about screening alone, there are also potential harms. There's a cost to the healthcare system. Dermatology examination means an increase in potential biopsies, which can increase invasive procedures and complications like wound infections. And patients become anxious when they have biopsies. We may not get the results for a week. So there are harms to consider. And then there are also obstacles for our patients. Some of our patients are sick. They have lots of doctor's appointments. They may not be well enough to do a more elective dermatology appointment. They may live far away. The referring physicians may not be aware of skin cancer risks. And then there are truly places where access to dermatology is a limitation. In rural areas, there are very few dermatologists, even fewer who take Medicare or Medicaid. And we did a poll of dermatologists at transplant centers around the U.S., and while some of them felt that they had the capacity to see every transplant recipient, at other centers where they do a high volume of transplants, they simply don't have the dermatology manpower to screen every patient every year. So we really want to target this screening to patients at highest risk. And there are lots of known risk factors for skin cancer after transplant. I've just shown you data, and that data is been reported in multiple other small single-center and multi-center studies showing that men have higher risk for skin cancer, older patients, patients with thoracic organs, and certainly patients who are white and not only of white race but also with fair skin and light eyes have a high risk. There's also something called Fitzpatrick skin type, which we talk about in dermatology. Fitzpatrick skin type is a 6-point measure of your skin's tendency to burn in the sun versus tan. And this feature is a risk factor for skin cancer after transplantation, independent of the race of the patient. So we will often talk about the constitutive pigmentation. This is a fair-skinned patient, but also the facultative pigmentation. This is a patient who burns. And both of those things are risks for UV-associated skin cancer. There are things we can't change, the pre-transplant risk factors. So patients who've had high levels of UV exposure in the past, patients who've had multiple sunburns or grew up or lived in hot or tropical climates have higher risk. Patients who've had skin cancer or actinic keratoses and even warts pre-transplant have a higher risk. And then there are the sun protection habits of the patients. People who cover up may prevent skin cancer. People who use sunscreen seem to have lower risk. So all of these things we can't change history, but we can modify going forward. And then there are the post-transplant exposures, and these have been studied here and there. They're very difficult to study because of the lack of comprehensive data, but multiple small studies have shown that monoclonal or polyclonal antibody induction increases the risk for melanoma and Merkel cell, as do immunosuppression with the older agents azathioprine and cyclosporin. The antifungal voriconazole is increased with risk of squamous cell carcinoma. I'll share some data about that. And then more recently, the mTOR inhibitor sirolimus has been shown to decrease squamous cell carcinoma, particularly in patients who've had at least one post-transplant SCC. So lots of ways that we can potentially modify post-transplant exposures. And even knowing these risks, we didn't know how we should best come to consensus about screening. And so what we did about 2 years ago was put together what we call a Delphi panel. A Delphi consensus panel is a structured formulaic method for achieving consensus among experts with anonymous surveys and aggregate results performed in multiple rounds until the experts are able to agree. And the reason it's done this way is to prevent the loudest person in the room from dominating the conversation, or to prevent the most senior person in the room from swaying the opinions of more junior people or people who are less convinced or confident of their own opinions. So we put together this panel representing 84 dermatologists and transplant physicians, roughly half and half, and you can see the details on the specialty and the years of training here in the table on the right. And we wound up doing 3 rounds of surveys to achieve 80% consensus on 3 specific topics. We wanted to know about risk assessment and skin cancer screening by full body examination. So 2 different things, who's at risk and who should be screened. Which transplant patients should be screened, and also when we should do these things. And these recommendations have been submitted for publication. They're endorsed by ITSE as well as the International Society for Heart-Lung Transplantation for use in the United States, because this was a U.S. panel. And here are the recommendations of the panel. The group agreed that risk assessment should be performed by the transplant team, and ideally either at the time of listing or at the time of transplant, so as early as possible. The panel requested the aid of an evidence-based risk stratification tool for risk assessment. Now, in the course of this Delphi panel, this was hypothetical, but ideally that risk assessment would be a tool that could be then completed in less than 5 minutes, and that could be completed by non-physician office staff. So something that could be very, very straightforward, perhaps part of a transplant checklist, something that a coordinator or nurse could do, something that wouldn't add to what we recognize as the heavy burden of care for these patients. The group agreed, both transplant and dermatology agreed, that screening itself should be completed by a dermatologist, and that this should be performed by full body skin examination. The other agreement of the group was that patients with a history of skin cancer should continue standard surveillance. And of course, we talk about screening post-transplant as a primary screening, but patients who've had skin cancer in the past may need a secondary prevention interventions and secondary screening. The the group tried to come to consensus on when patients should be screened, but were only able to come up with a very loose consensus. They identified high-risk patients as ones who had any one of the following characteristics, and you're going to hear me say things I've said before this afternoon. Patients who've had thoracic organ transplant, patients who are over the age of 50, and patients who are male were considered high risk. Patients who had none of those above features were considered lower risk. And overall, the group thought that high-risk white patients should be screened sometime within the first 2 years after transplant, whereas low-risk Caucasian, Hispanic, Asian, and high-risk African American patients should be seen sometime within the first 5 years. The group was not able to obtain consensus on whether or when low-risk African American patients should be seen. So this is not a particularly useful recommendation. It gives you a general sense of when patients should be referred, but the group also felt that a threshold for screening would be 50 patients to detect one cancer, that if we had data showing that 2% incidence was in that population, then they would want to refer that patient. So what did our group do? Well, the first thing we did is we reviewed the existing tools, because the transplant docs asked for a risk prediction tool. And there had been 3 published in the literature. All 3 of these were specific to single centers in the UK or Australia. As you can see, the sample sizes were very small, under 400 patients for all 3. And all of these were white kidney transplant patients, so not particularly generalizable to our multi-organ, multi-ethnic U.S. transplant population. The other thing about the risk predictors in these existing tools was that the majority of them required getting some information from the patient. So the color of their eyes, whether they were born in a hot climate, if they lived in a hot climate, if they'd ever had daily UV more than an hour. These are things that take a patient visit or patient survey to understand. And we thought we could do better. So since we had the data from the Transplant Skin Cancer Network, we decided to build this data into a tool that would satisfy the requests of our Delphi panel. And this tool actually just got published last week, and it's called SUNTRAC, or the Skin and Ultraviolet Neoplasia Transplant Risk Assessment Calculator. And this is a 5-minute evidence-based tool. It's based on the data from the Transplant Skin Cancer Network Incidence study. And what we did to develop this tool was to look at our main 5 skin cancer risk features and assign points based on the relative beta coefficients in a multivariate model. We then used recursive partitioning to separate these point scores into 4 clearly defined categories, and you can see them best on the cumulative incidence plot on the right. In red, we have the very high-risk patients, the patients who have multiple of these high-risk features. In orange, we have the medium-risk patients. In orange, we have the high-risk patients. In yellow, we have the medium-risk patients. And then in green, we have the low-risk patients. And you can see with the incidence plots and the confidence intervals around them that these patients behave very differently with their skin cancer incidence over time. There is a black line horizontally across the graph, which represents that 2% screening threshold. And so what we have decided to do is recommend referral for screening based on these risk categories and when they cross that 2% threshold. So we've made it even easier for our transplant physicians by converting this data into a nomogram, where you can basically answer the 5 questions, and patients are sorted into the 4 different categories. So for low risk, we recommend screening within 10 years. For medium risk, within 2 years. For high risk, within 1 year. And then very high risk to screen within 6 months. And of course, any patient who has a pre-transplant history of skin cancer should also continue their routine surveillance as recommended by a dermatologist. That may be annually, or if they had a single skin cancer 10 years prior, they may not be seen as frequently. So these will really help our transplant providers in understanding when to refer and also targeting screening at the highest risk patients. We have also built an app for this tool. a calculator which is going to be available on the App Store in the next week or two called SUNTRAC. And again, you simply click on the different features of the patient, and it gives you both the cumulative incidence of skin cancer at 5 and 10 years, the recommendation, and then there's information which shows that incidence curve that I showed you a couple of slides back. So we're hoping to be able to put these tools in the hands of our providers and hoping to encourage our providers to talk with their local dermatologists about how we can target screening at the patients who need it most. Now, as with any medical tool, there's always caveats and considerations. Screening specifically applies to asymptomatic patients, patients with no active lesions. Patients who have had a skin cancer should be seen as directed by dermatologists, and any patient with a concerning lesion or a new lesion should just be referred for evaluation, right? That's not screening, that's referral for evaluation of something specific. We know that this simple tool gives us good data on who the highest risk patients are, but it is not as precise as a tool that involved patient-specific risk factors like sun damage, UV exposure, specifics about pre-transplant immunosuppression, and other features. Those things may change a provider's view on how high or low risk a patient is. So these broad categories can be personalized to the patient. And then it's really important to think about this tool as a tool for screening for UV-associated squamous cell and melanoma. It does not incorporate risk for Kaposi's sarcoma or genital dysplasia, and those two in particular may be higher in transplant recipients of color and HIV-positive transplant recipients. So even if those patients are low risk for a melanoma, they may be high risk for genital dysplasia, and so continuing to assess our patients for their own particular needs is really important. So when I see a patient, what do? I do a personalized risk assessment, and again, these are the same features that we've talked about earlier. And I assess patients for what I consider field cancerization. So I'm going to switch now and talk about things that we can do to help treat our patients who come in for screening or come in at high risk for skin cancer for evaluation of concerning lesions. In the cancer field, we call field cancerization a broad area of pre-neoplastic change due to carcinogen exposure. And in the case of cutaneous or skin cancers, the carcinogen is ultraviolet radiation. In lung cancer, it may be cigarette smoke. In genital cancer, it may be papillomavirus. So here we're looking for UV-associated cancers, and sometimes UV radiation leads to subclinical changes. But cancerized fields develop multiple primary and locally recurrent tumors. And as you can see on the scalp of this patient of mine, he has normal skin. He has areas of pre-cancerous actinic keratoses or dysplastic cells within relatively normal epidermis. When those cells fill the entire epidermis, we develop squamous cell carcinoma in situ, and then as those cells invade into the dermis or the next layer of the skin, we develop invasive squamous cell carcinoma. So we can spot treat actinic keratoses. We typically do that with liquid nitrogen spray. But for many transplant patients, it's better to do a more aggressive and also more preventive field treatment. And field treatment means applying therapy to the entire sun-damaged area, either by a topical cream or a light treatment, to attempt to identify and treat both clinical and subclinical cancerization. And I could give a whole talk on field therapy. I tend to give that only to the dermatologist when I'm talking about transplant patients. But I wanted to give your group a framework of the stepwise approach that I take and many dermatologists take when we're looking at these patients. So for mild patients, there are topical diclofenac and topical imiquimod, which is an immune modulator but safe to use in transplant patients. And we may treat the patients once a year, see them every 6 months, spot treat what's left. And then there's some newer data I'm going to share with you about nicotinamide. When patients have more moderate field disease, then we tend to become slightly more aggressive with either topical 5-fluorouracil chemotherapy or photodynamic therapy with blue light. Both of these, again, are safe to use in transplant recipients. And then there's a third agent, which is newer. It's only approved in 2012, which is topical ingenol mebutate. And again, we've just finished a safety study of this in our transplant patients. So these are all ways that we can treat field disease. I tend to weigh patient preference into a lot of these treatment decisions because they are all relatively similarly effective. The recent data shows that 5-fluorouracil probably has the best efficacy and duration of response, but it's not always tolerated by every patient, and so it's nice that there are other options out there. When patients are developing more severe actinic dysplasia and they have multiple skin cancers as well in the field, then we talk about a more aggressive approach with systemic chemoprophylaxis using oral Acitretin. I'll talk a little about that. And that's something that we always discuss with the transplant team. Chemoraps are a combination of fluorouracil under occlusion that we tend to do for areas like the arms or the hands in patients where none of the other approaches have helped. And then for those intractable patients, people have tried oral 5-fluorouracil and oral capecitabine in transplant patients. I think it's relatively difficult to prescribe and maintain those medications, and obviously dermatologists need to be discussing that with the transplant team in the context of other agents. So here's some of the data behind this approach. Nicotinamide made a big splash a couple of years ago when a randomized control trial was published in the general population, looking at 386 immunocompetent subjects with at least 2 skin cancers in the past year, and nicotinamide was protective against keratinocyte carcinoma, basal and squamous, during treatment, but not afterwards. They did a phase 2 study in 22 renal transplant recipients. It was not significant in that small population, probably underpowered. The effect size was similar. And because of this, many dermatologists are recommending nicotinamide, which is an over-the-counter vitamin. I personally am discussing with the patients the lack of evidence and the potential for it to be helpful, but also the fact that we truly don't know for sure. Acitretin, on the other hand, which is a vitamin A derivative, has been used for years for chemoprophylaxis, primarily against squamous cell carcinoma. These are 3 of the strongest papers showing an effect, and in fact there are now multiple meta-analyses showing that acitretin is effective in reducing squamous cell carcinoma risk, so it has become a standard of care for our transplant patients. I consider acitretin chemoprophylaxis in patients who have either more than 5 non-melanoma skin cancers, so primarily squamous cell carcinoma, in a year, patients who have an accelerating frequency, patients who have uncontrollable actinic keratoses, so I just know they're going to develop a skin cancer. I started in any patient who has a high-risk skin cancer. I say that I started in patients with metastases, although I find at that point it's a little bit late to be talking about prophylaxis. And I tend to coordinate with the transplant team to start low and hit a target of 25 to 35 milligrams per day. It depends on the tolerance of the patients. It may elevate triglycerides. It makes patients' skin very, very dry, but it doesn't interact with any of the transplant medications, and our pharmacists have been very happy to have it on board. Early in my career, I think I started acitretin too late. Now I'm starting it earlier if patients want to be more proactive, and I think it's an important thing to think about. Voriconazole is an agent that I did a lot of work on some years back because we started to see a significant increase in squamous cell carcinoma in our lung transplant patients who were receiving antifungal prophylaxis with voriconazole. It had a known photosensitizing effect from its labeling studies, but mainly they studied acute photosensitivity, so sunburns in patients on Vori. We found that actually chronic sun sensitivity and dysplasia also occurs in these patients. And you can see on the upper left, there's an almost 2-fold increased risk of squamous cell carcinoma. That really has to be balanced because on the lower left, Voriconazole does reduce colonization with aspergillus almost twofold, and of course that's the reason we use it. And it also it also improves overall survival in lung transplant patients. So we really have to balance the squamous cell cancer risk against the aspergillus risk. And so more recently, we're really trying to target voriconazole towards patients who are at low risk of skin cancer and use other agents for patients who are at higher risk, like posaconazole. Sirolimus is an mTOR inhibitor that has been shown to reduce non-melanoma skin cancers in renal transplant recipients in multiple studies. And here's a forest plot showing that in at least 20 randomized trials, the incidence rate of skin cancer with sirolimus was 0.7. And primarily this was driven by reduction in the incidence of non-melanoma or squamous cell carcinoma. Sirolimus seems to be the most effective in association with a switch from cyclosporin to sirolimus. A lot of studies were randomized to switch from calcineurin inhibitor to sirolimus, and obviously this has to be balanced against the side effects of sirolimus. Leg swelling is the primary reason my patients can't tolerate it. Sirolimus is also associated with a high risk of wound dehiscence, and so for patients having invasive surgery, they can't be on sirolimus, and so there really does need to be a balance here. So transplant providers and dermatologists need to partner together to reinforce sun protection, to ask about new lesions, and to consider these medications. So then in the last few minutes of this talk, I want to give you some information that maybe you'll have an interest in just as a general layperson for yourself and your family, but also for our transplant patients. And that's how I counsel about sun protection. Because regardless of whether a patient is at high or low risk for skin cancer, all of our patients are being exposed to the primary carcinogen, and that's ultraviolet radiation. UV radiation is measured by the Environmental Protection Agency, and they publish daily huge amounts of data about it. And so this information is available to us as providers and to our patients. They report on UV levels on their website, which is listed here. They have a smartphone app available, and you can actually put in your zip code and see what your UV index is. Here, this U.S. map on the lower right shows our UV index yesterday. And as you can see, where I live in red, it's in the very high range. Down in Florida, it's in the extreme range. Still pretty low in the Midwest, so perhaps less of a need to cover up in those low areas. But again, you can see that sun exposure and UV radiation is really higher than patients think it is. So this can help maybe motivate them to appropriate sun protective behavior. And what are those behaviors? Well, number one, first and foremost, is sunscreen. Sunscreen, sunscreen, sunscreen. And I give the lecture the same way the dentist will lecture patients about flossing. I will give the lecture about sunscreen every time I see a patient. Patients need to use a broad spectrum. Anyone will do, but it's got to have at least SPF 30, and it has to have both UVA and UVB coverage. That SPF is developed through testing, and it always has the caveat when used as directed. And sunscreen used as directed is a lot of sunscreen. I have a little picture of a shot glass here to show my patients that that's 2 ounces. And it takes 1 to 2 ounces to cover your entire body. An average bottle of sunscreen is 4 to 8 ounces. So we should be using it up in a week at the beach. You have to reapply it every couple of hours, and certainly after swimming or sweating or toweling, because even if it's waterproof, it's not towel-proof. And then I tell patients to look for one they'll actually use, that personal preferences really drive the adherence to sunscreen, and if they buy the one that I use and they don't like the way it smells, they're just going to put it in their medicine cabinet and forget it. It's important to replace it every summer. It does expire after a year, but patients should be using it up long before that. And then I tend to give patients some tips about moisturizers and makeups and other things. I personalize that towards the specific patient and what their outdoor activities are. I've directed a lot of patients to this really fun video called How the Sun Sees You, which uses ultraviolet light to demonstrate how our sun damage is usually not visible to the naked eye, and that sunscreen, when you put it on, appears black under ultraviolet light. So you can see this woman who's applying sunscreen to her cheek under the UV light, and it appears black. That is showing how the sunscreen actually protects against sun damage. And more recently, there's been a lot of controversy about whether sunscreens should be chemical or mineral, and that really depends on the ingredients used to prevent the sun from damaging the DNA of the skin. There are pros and cons to both, and I will often talk to patients about those pros and cons. We simply don't have the data for safety on the chemical sunscreens. They were approved before the FDA was requiring this type of safety data. And so while we know they're absorbed, we don't know what the biologic effects are, and those studies are currently underway. For my swimmers and surfers and scuba diving patients, we do know that 2 of the ingredients in chemical sunscreens are toxic to coral reefs, and within the next 2 or 3 years, these agents are going to be banned in Palau, Hawaii, some parts of Florida, and probably more places will take this up. Now, everyone might say, well, if mineral sunscreens are safer, why don't we all use them? They feel waxy. They feel heavy. They have a white sheen, and most of my patients don't like them. And given that we don't have clear data that chemical sunscreens are unsafe, I personally continue to use a chemical sunscreen until we know more. And I advise my patients that what's most important is having some sun protection. Now, there are patients who don't want to put on sunscreen, and there are sun protective clothing. And sun protective clothing does the same thing. You don't have to reapply it. And when I started giving this type of talk 10 years ago, there were not that many options on the market. Now you can find clothing with ultraviolet protection everywhere. So I really encourage my patients, if they're golfers, look in the golf catalogs. If they're gardeners, look in the gardening catalogs. If they're surfers, look in the surfers catalogs, because there's something for everyone. And every patient needs to wear a hat. These are my hat ratings. I think hats need to cover the top of the scalp. They need to protect the ears. So visors and baseball caps really don't. A hat with a broad brim is preferable. A mesh hat only gets a rating of C because the light comes right through that mesh. So in order to really get an A from Dr. Arron, you need to have full coverage, big broad brim, and then most recently I found this extra credit pink hat versus hat neck and overall cover up with the backs of the hands. I love that, but I haven't got any patients buying them yet. And then there are fun things you can do like UV beads and silicone bracelets that change in the light. So those are great for team building or making as handouts sometimes when I do a patient talk. And patients will ask me, what about vitamin D? Don't I need the sun for vitamin D? And the answer is no. It is true that we make vitamin D in our skin, and that ultraviolet B radiation is required for that chemical event to happen. And sunscreen blocks up to 95% of vitamin D production in the skin, but the same vitamin D is obtained through a healthy diet without the skin cancer risk. And here in the U.S., we fortify our milk, our yogurt, our cheese, our cereal with vitamin D. So there should be plenty of ways to get vitamin D through the diet. Fatty fish is naturally a rich source of vitamin D, as are egg yolks and cod liver oil. And then I recommend that patients who aren't able to eat a healthy diet or don't want to eat these things discuss supplementation with their physicians. Particularly for my renal transplant patients, I don't want them to start vitamins without discussing it with the team. But vitamin D deficiency due to sunscreen use is extraordinarily rare. And I tell my patients, if you're able to be so compliant with your sunscreen that you develop vitamin D deficiency, I will give you a gold star, because I've never seen it happen. So finally, our take-home points. Skin cancer is a huge cause of post-transplant morbidity and mortality. I hope I've convinced you of this today. Those of us in dermatology really want to work with you to optimize our patients' care. Please refer patients for screening according to their risk, but don't hesitate to refer anyone for any reason. If you have no time to risk assess, just refer to us and we'll risk assess. If you want us to educate patients, we're happy to do it. Lots of us come and do lunch and learns or sun protection lectures to our pre-transplant and post-transplant support groups, and there's most likely someone in your area who's just waiting to hear from you. We have more information available on our website. These are two of my patients who graciously offered to be the poster children on our website at skincancer.ucsf.edu. We have an informational pamphlet that your patients can download in English or in Spanish that goes over much of this. And then future research in this area. We're really passionate about getting patients involved. And so if your patients are interested in signing up, they can do a simple online survey at this website. And if they even want to go one step further and participate in our genetic studies, we're offering free 23andMe to patients who are interested in participating in that. So please do send your patients our way, send your providers our way. We are happy to help in any way we can. Thank you for your time.
Thank you so much, Dr. Arron, for such a great presentation. Before I turn it back to Becca to moderate your questions, I'd just like to remind everyone that if you do have any questions for our presenter, please be sure to submit them using the chat feature. Again, that's going to be located in the bottom left-hand corner of your screen. Also, during the Q&A time, I'll have this poll up for all of you. For those of you who are listening in a group, if you could please just complete this poll and let us know how many people are actually participating in your group, that would be greatly appreciated. Thank you. At this point, I'll turn it back to Becca to moderate your questions.
Thanks, Deanna. And thank you, Dr. Arron. That was a great presentation. I'm sure everyone is sitting around looking at their skin after seeing all those pictures. We do have one question up here wanting to know when the SUNTRAC tool is going to be available.
So I'm very excited to say that because the paper came out last week, we have the app available. It's in the App Store now, but it's awaiting Apple approval for smartphones on the iOS system. It takes a couple of days to go through the App Store, and then it should be free to download. And it should also be available on the Android store at that time. And all credit goes to Mark Melcher, who's a transplant surgeon at Stanford University who built this app for us. I'm also happy to send the nomogram out to any site that's interested in packets or more information. They should please feel free to contact me by email. Hopefully my email will be available to webinar participants if they prefer to use that tree nomogram algorithm and carry it in their pocket. We're making those as well.
That would be very helpful. I guess one of my questions is, as you know, there's a lot of information in the news recently about, safety of sunscreens. I've heard that, you can absorb the chemicals, if you will, in the sunscreen. Is that something that we should be concerned about?
I think we should be concerned about that. There was a scientific paper came out recently that showed that some of the chemicals in chemical sunscreen, and particularly the oxybenzone, is absorbed through the skin and can be detected in the bloodstream of patients. Now, many things are absorbed through our skin, and many things can be detected in our bloodstream, and then we filter them out, and that's the end of it. And they don't go on to cause any biologic effect. But because these data are now available, the FDA has requested sunscreen companies do additional safety testing on sunscreens that contain these chemicals. And so that testing is underway. I think we have a challenge in that we don't know if something is safe until it's proved dangerous, or is it dangerous until it's proved safe? And chemical sunscreens have been used for years, and we haven't seen huge changes in the safety of patients who report using it, but we really don't know. And I'm going to add on top of that, we don't know if the excretion of those sunscreens is impaired in transplant recipients or not. I don't know. It gives me something to stay up at night worrying about. On the other hand, I could worry about a lot of things and unnecessarily because we know what the cancer risk is, and the cancer risk is significant. So I tell my patients that I personally continue to use a chemical sunscreen. If they are concerned about safety, I will recommend to them mineral sunscreens. And there are some mineral sunscreens that have a more elegant feel to them. They tend to be the more expensive ones. There are certainly less expensive ones that are titanium and zinc. And titanium and zinc sunscreens don't get absorbed into the skin. They sit right on top of the skin. So if my patient's primary concern is the chemicals, then I tailor my sunscreen recommendations to that. In the same way, patients who are sensitive or have lots of skin allergies tend to do better with mineral sunscreens. So for those patients, I recommend it. Then there are patients who want to wear makeup and they say, I can't use a zinc sunscreen. It makes me look like I have a white sheen, and then I put my foundation on and I look strange. And I tell them, if that's your primary concern, then let's do a chemical sunscreen. Let's find you one that you like. Because the most important thing to me is that everyone be protecting themselves from the sun.
We have another question here. Patients have asked if their PCP can monitor their skin. Should all transplant patients see a dermatologist if available?
This is a terrific question. Actually, when we did our Delphi panel and we asked the teams who should be doing skin cancer screening for our patients, we put as multiple choice options primary care provider as one of the options. Now the group chose dermatologists as the first choice, primarily because a dermatologist is going to spend the entire visit doing that skin cancer screening, parting the hair, looking in the eyelids, checking all around the ears front and back, looking in the mouth, in the genitalia. It's a pretty extensive screen. I think that patients absolutely can go to their primary care doctor, particularly if they have a relationship with their primary care and their primary care is comfortable doing that. The challenge is that most primary care doctors are working in a pressured healthcare system where they are juggling lots of different issues, diabetes, heart disease, other concerns for the patient. And so the skin cancer screening, quote unquote, may wind up being a simple looking at the patient's back while you're listening to their lungs. And that's not quite enough for our transplant patients. They really do need to have their bodies looked over, particularly if they're in that very high or high risk group. What I'm suggesting to patients now is that if they're in that lower risk group, then why not ask your primary care doc to take a look and see if they see anything strange. But really a head-to-toe screen should be done by a provider who's dedicating the time to that. And if the primary care doctor is willing and able to do that, then absolutely the patient should see them. And if the patient is in an area where there is no dermatologist available, then absolutely they should just ask their primary care doctor and advocate for themselves, can you please look me over head to toe and make sure there's nothing concerning.
I think that the education for our patients is very important, that they understand what their risks really are. I think we overlook our skin risks a lot.
It's a real challenge because much of the time when our patients are receiving their education blitz, they're either pre-transplant when they're so concerned about the reason they're getting a transplant and their health through that surgical period that they really can't absorb all of the information at once. And in the immediate post-transplant period, there's a lot. There's a lot to absorb, new medications, schedules, doctors, other screening. And skin cancer being a late post-transplant complication means most people don't think about it until later. If I could come up with the easiest way to target education to patients early on in a way that they were ready to absorb it, I would absolutely do that. And for some patients, it may be a referral to a dermatologist just to have that conversation, in the same way that you need a separate conversation with a nutritionist to talk about food, or a separate conversation with social worker to talk about family stressors. It may just be that carving out that time is the best for our patients. Some patients may want to learn it online or through support groups. So we all can work together to make as many tools as possible and have them available for when the patient is ready to receive them.
And I don't see any further questions.
All right. Well, thank you, Becca, and thank you, Dr. Arron, for facilitating that Q&A session. On behalf of the Alliance, I'd just like to extend our sincere thanks to you, Dr. Arron, for joining us for today's webinar and for sharing your expertise on such an important topic. And additionally, I'd like to extend a sincere thanks to Becca for taking the time to join us and moderate today's presentation. So thank you both. To all of our participants, I'd like to once again apologize for today's delay, and we thank you for your patience and appreciate you taking the time to join us for today's presentation as well. We hope you enjoy the rest of your day, so take care.
Bye.